Assalamu alaikum, Bismillah Rahman Rahim. I hope you all will be doing fine back at your homes, and just keep praying for all of the Muslims and all other people around the world. May Allah keep us safe from this situation. Um, Today we are going to discuss about orthopedic and musculoskeletal conditions. We will be discussing this lecture in 2 weeks, one half of the lecture this week and half of the lecture in the other week. Um, so let's start it. Orthopedic and musculoskeletal conditions. For that purpose, first of all, we need to know about the growth and development of the bony skeleton. The skeletal system developed from the mesodermal and the neural crest cells. So the skeletal systems develop from the mesoderm. You are well aware what is the mesoderm and what is neural crest cells. Neural crest cells are basically the cells which arise from the ectoderm layer. So the skeletal systems develop from the mesoderm layer and the ectodermal layer. Then somites are formed from the paraxial mesoderm and differentiate into the sclerotomes, dermatomes, and myotomes. Sclerotomes are the ones which give rise to the bone and the skeletal tissues. Then there are dermatomes and the myotomes. Sclerotome cells migrate from somites and ultimately become the chondrocytes. Remaining dermatome cells from the dermis. Myotome cells gives rise to striated muscles of the back of the limbs and respective girdles. The appendicular skeleton are derived from cells of the lateral plate mesoderm. So these all are the very initials of the development. Then the limb bursts appear in utero approximately at day 26 for the upper extremities and at day 28 for the lower extremities. The hand plate forms in the 5th week with digitization of rays in the 6th week. Notches appear between the rays in the 7th week, failure of which, if the notches does not appear and it results in webbing of a partial or total webbing of the fingers or toes, and this condition is known as syndactylism. We will discuss this condition later on. During the 7th week, the limbs also rotate laterally in the uppers and medially in the lowers. This brings the thumb to the more lateral position in the upper extremity and the great toe to the more medial position in the lower extremity. Then what is chondrification? This is the process by which cartilage is formed from the condensed mesenchymal tissues. It begins in the 6th week, which is followed by early ossification in the 7th week, and the subsequent joint formation in the 16th week. By the 8th week, definite muscle formation is noted as the embryo assumes a human appearance and basic organ systems are completed. The fetal period begins at 9 weeks with rapid growth and changes in the body proportion. So all are the changes which are happening from day to day and from week to week in your during the time of the body development. Now let's discuss the congenital conditions we have. Minor limb deficiencies are relatively common in the upper and lower extremities. The first is syndactyly. It occurs in approximately 1 in 2,200 birds, either as cutaneous with simple webbing of the fingers or osseous with fusion of the bones when the digital rays fail to separate between the 5th to 8 weeks of gestation. You see, this is here it is the webbing between the two digits, between the two fingers of hand. This is incomplete syndactyly, and this one is complete syndactyly. And here you can also see this webbing on the in the finger of the foot. As we have discussed, it is most frequent in the 3rd and 4th fingers. So this is 3rd and the 4th fingers, and between the 2nd and 3rd toes, likewise 2nd and 3rd toes. Surgical separation of digits is more common with complete syndactyly for functional and the cosmetic reasons. So the functional cosmetic purposes surgery can be done for this purpose. Polydactyly has an incidence of approximately 1 to 1.5 per thousand live births and is most common congenital toe deformity. 80% of polydactyly in the foot occurs with the 5th toe. Surgery around the age of 1 not only improve cosmesis but is also helpful in facilitating the shoe fitting. So you see here this is polydactylity, having the more number of fingers than the normal compactodactyly. This means bent finger. The proximal interphalangeal joint is flexed, most commonly at digit 5. You see this proximal interphalangeal joint is flexed, and most commonly this is the digit 5. Incidence is felt to be more than 1% of the general population with equal gender. Appearance in adolescents, often in girls, is less common. Surgical reconstructions are for functional and cosmetic reasons. So, all these three conditions, the syndactyly, polydactyly, and compactodactyly, have the facility of the surgery with them. Malformations of the radius are common than those of the ulna and are associated with numerous syndromes. Simple and multifactorial inheritance may all be causative in addition to teratogenic effects, such as maternal exposure to viral infections and chemical dependency, such as alcohol. Then we have another deformity known as the Springer's deformity. This is the failure of scapula to descend from its cervical region overlying the first through fifth ribs. You can see over here, this is the inability, the failure of scapula to descend from the cervical region. Children often present with a shortened neckline, lack of normal scapulothoracic motion, malpositioning of the clinoid causes limited forward flexion and abduction of the shoulder. So it is very obvious when there is malalignment of scapula, the neckline will be shortened and there will be a lack of scapulothoracic motion, which is going to limit the forward flexion and the abduction of the shoulder. Then we have omovertebral bar. What is omovertebral bar? It is present in up to 50% of the cases. The bar connects between the supermedial angle of the scapula and the cervical spine and consists of fibrous cartilaginous tissue or bone. So you see at the supromedial angle of the scapula, there is a bone or cartilaginous tissue fiber which is connected to the cervical spine. This is known as omovertebral bar. Congenital radioulnar synostosis. It's a rare condition caused by the failure of radius and ulna to separate, usually proximally. The forearm is usually left in significant pronation, with condition bilateral 80% of the time. You see, this is the synostosis of radioulnar bone and of right elbow, and this is synostosis of left elbow. This is also the synostosis. Next is congenital dislocation of the radial head, accompanied by other congenital abnormalities of elbow or forearm. It is rare acquired dislocations, account for 6 to 8% of elbow injuries. They are most frequent in children under the age of 10. Typically, the injury involves a non-dominant extremity with a fall on the outstretched hand. So this is the congenital dislocation of the radial head, and it is most frequent under the children of 10, and the mechanism of injury is fall on the outstretched hand. Then we have this nursemaid's elbow. Consists of a radial head subluxation from a sharp upward pull on extended pronated arm in preschoolers, as you can see over here, a sharp upward pull on the extended pronated arm. A generalized ligamentous laxity in children with large cartilaginous components of distal humerus and proximal ulna. In addition to osseous instability with numerous secondary ossification centers and epiphyses, all contribute to tendency for the pediatric elbow to dislocate. Posterior or posterolateral dislocations account for 80% to 90% of the injuries. Close reduction with patient under sedation is the treatment of choice. You can follow the patient with the close reduction or the longitudinal traction and flexion the supinitial will reduce the uncomplicated dislocation. So you see here, this is the nursemaid's elbow. Ligament is trapped over here. We have ligamentous laxity over here, and this is the mechanism of injury in which sharp upward pull is done on the extended pronated arm. The next we have is the Klippel-Feil syndrome, sometimes called as brevicollis. So we call the Klippel-Feil syndrome as brevicollis as well. It is characterized by the short neck, low hairline, restricted neck movement. Consisting of congenital fusions of cervical vertebra, its incidence is approximately 0.7%. Failure of segmentation of cervical spine most often characterizes the Klippel-Feil syndrome. So this is the Klippel-Feil syndrome. You can see it over here. It's also resembling to the Springer's deformity, but the reason mainly over here is the failure of segmentation cervical spine, which results in the short neck, low hairline, and restricted neck movement. Next, we have clubfoot. Clubfoot or talipes equinovarus is a common term used to describe several kinds of ankle or foot deformities present at the birth. The foot is generally in equinus with forefoot and hindfoot varus and square abduction. As the most common birth defect, it carries an incidence ranging from 1 ratio 250 to 1 ratio 1000 live births, depending upon the population. The condition is one of the most treatable birth defects, often leading to normal or near normal athletic activities later in life. So it's the most treatable congenital defect. This is the clubfoot, inversion of calcaneus, forefoot bones in the varus, talus in equinus and varus, and plantar flexion of ankle joint. Metatarsus adductus. This can be seen in up to 12% of full-term births. Flexibility can be determined by fixing the hind foot in a neutral position and gently manipulating the midfoot and forefoot to a more lateral position. You see, this is metatarsus adductus. This is normal foot with a normal alignment, and in metatarsus adductus, the foot becomes C-shaped, or it can also become S-shaped, and it becomes deviated inward. And the deviation is because of the metatarsal bones. Here you see a boy which is 6 months old with metatarsus adductus. You will allow the individual with the foot orthosis, and ultimately this will result in the normal foot within 14 days. Internal tibial torsion may be associated, making the thigh foot ankle worse. Serial casting may be helpful in children under the 1 year of age. Careful attention should be given not to place the hind foot in valgus or create a skew foot deformity. Surgery is rarely indicated but can be done in more rigid, persistent deformities after the age of 5. Various forms of posterior medial release are available. Flat feet or pes planus may be flexible or rigid. You see, this is the normal arc of the foot, and this is flat foot having no arc. Flexible plus planus is usually asymptomatic, at least in early years, and is the most common type found in children. Inexpensive scaphoid pads or medial inserts may be helpful to create more plantigrade weight bearing in the child, but they do not correct the deformity. In extreme cases, such as in children with hypotonia, it may require surgery after the age of 5 years in the form of calcaneal lengthening. So you see, you can provide them with inexpensive scaphoid pads or the medial inserts, but that is not going to correct the deformity. And in other severe cases, suppose if the children is having hypotonia, are having hypotonia and their age is about 5 years, so the surgery can be given in the form of the calcaneal lengthening. You can see it over here. These are the custom-made flat foot insoles for the purpose of creating the, you know, arced sole. This is the management of plus panus, including the heel cord stretching. Orthotics may be used and obviously reduce the contributing factors. Then surgery includes the possible surgical procedures includes the Achilles tendon lengthening, calcaneal osteotomy, reconstruction of tibialis posterior tendon for severe midfoot collapse of the arc. Triple arthrodesis may be indicated as well. Then we have the navicular bone, which gets dislocated dorsolaterally on the head of the talus. It is commonly associated with the neuromuscular and genetic disorders, including the trisomy 13, 14, 15, and 18. So whenever there is dislocation of navicular bone on the talus, we can assume that it is related to some neuromuscular genetic disorder. The clinical feature of the following dislocation is uh, it includes the rigid convex plantar surface, known as rocker bottom surface, with the hind foot equinus and hypoplastic laterally deviated forefoot. Casting obviously can be done initially, which will going to have benefit for contracted dorsolateral soft tissue, and only as a prelude to surgical intervention. A single stage procedure involves talectomy, naviculectomy, subtalar arthrodesis, and triple arthrodesis. Arthrogrypyrosis multiplex congenita refers to a symptom complex characterized by multiple joint contractures that are present at the birth. So you see over here, this is the condition of arthropyrosis multiplex congenita, and you can see this poor baby with a lot of contractures, multiple joint contractures. Then we have amyloplasia. It literally means no muscle growth. Affecting all the four limbs is less common at approximately 1 in 10,000 live births. Larsen syndrome is a rare condition involving multiple congenital dislocations of large joints and flat faces and significant ligamentous laxity. So, in Larsen syndrome, we are going to have a number of dislocations at all the large joints, flat faces, and the significant ligamentous laxity. Then this is multiple Taiges syndrome. It is characterized by webbing across every flexion crease in the extremities. So you are going to see the webbing. Here is webbing. This is the front and this is the back. Here's the webbing and on the flexion creases. So almost all the flexion creases, the popliteal space, the elbow, the axilla, there is going to be webbing. Popliteal pterygium syndrome has features involving face, genitals, and knees. A popliteal web is usually present bilaterally running from the ischium to calcaneus and resulting in severe knee flexion deformities. So, whenever you are going to see a webbing in the flexion deformity, in the flexion crease, you'll know this is multiple pterygium syndrome. So now let's move towards another topic, which is brachial plexus palsy. But brachial plexus injury occurs in between 1 to 2 per thousand live births in United States. Babies who are at increased risk, increased birth weights, multiparous mothers, and shoulder dystocia. So, which kind of babies are in increased risk? The increased birth weight with multiparous mothers and the shoulder dystocia. The most widely described mechanism of action for this is lateral stretch, which is logically secondary to the location of the brachial plexus. The high correlation with shoulder dystocia and the positioning of the mother and the infant. So you need to know what is shoulder dystocia. Right after the delivery, if the hair of the baby, the interior side of the baby's head gets stuck inside the mother's pubic bone. So this is shoulder dystocia, and the sign of such a symptom will be that baby's head will retract back directly into the vagina. This is known as the turtle's sign. So that is shoulder dystocia. If it happens, the mechanism of action is the lateral stretch. So it has been described that between 50% to 94%, 95% of these infants will recover spontaneously. For any nerve that is injured, classification makes evaluation and comparison clearer. The SEDENS classification of nerve injury is commonly used. Neuropyrexia occurs when no lasting anatomical changes with fibers preserved. Axonomesis is the condition in which there is an interruption of neural continuity to some degree. There is an extremely variable level of deficit that is difficult to evaluate and predict the degree of recovery. Neuromesis is most severe injury with total disruption of the elements of the nerves, and this will not recover. If it is preganglionic or proximal to the dorsal root ganglion, it is called an avulsion. If it is postganglionic or distal to the dorsal root ganglion, it is called a rupture. Both of these require the surgical intervention or recovery. So you have studied this sudden classification of the injury previously as well. All right, there are also descriptors for the level of brachial plexus injury. Now, let's see what are the most common levels for the brachial plexus injury. Injury can occur at C5 to C6, which will be known as Erb's palsy, sometimes called Erb Duchenne palsy. This is the most common level of involvement, which is present in approximately three-fourths of those with birth brachial plexus palsy. Then there's involvement, there can be involvement of C8 to T1, and if there is involvement of such level, then it will be known as Klumpke's palsy. But it is debated whether Klumpke's can occur in the birth brachial plexus injury, though it definitely occurs in other types of brachial plexus injury. The reason for this question is whether is it anatomically possible to have C8 T1 lesion alone without the involvement of C5 C7. It appears that if there is an anatomical variation, for example, a rib, tendon, bony, or other anomaly that leads to a C8T1 compromise, this can occur in a birth brachial plexus injury. Otherwise, it appears that it cannot. Therefore, if a child presents with C8T1 birth brachial plexus injury, it may be from anatomical anomaly, but there are two other options to consider. Most likely, it was initially a complete brachial plexus involvement, but there was a quick recovery of C5 to C7. There is likely since This is likely since the upper cervical root levels are relatively protected anatomically, so C8 and T1 may end up with more severe injury. It is also possible that the spinal cord injury has been mistaken for brachial plexus palsy. All of these are important to consider during evaluation. There also may be complete brachial plexus palsy, including C5T1 with total motor and sensory loss. There can also be a variety of levels involved between the upper plexus and the total plexus palsy. Excuse me. Then we have evaluation. The evaluation includes the clinical findings and the electrodiagnosis and the MRI. In clinical findings, we have the history and the physical examination. In electrodiagnosis, we have the sensory nerve conduction and the motor nerve conduction along with electromyography plus MRI. History. While taking the history of such patient, you need to consider these points: the birth number of the child, the birth weight, the presence of maternal diabetes during the pregnancy, the size of the previous infant, the birth size of the parents, the motor and the sensory findings at the birth. Any change up to the time of evaluation, the use of vacuum or forceps may be indicative of any difficulty with delivery. And the most common association is obviously shoulder dystocia that we have read up till now. Other useful information is whether there were signs of bruising or other injury, or whether there was involvement of contralateral arm or the legs at the time of the delivery. Physical examination. While doing physical examination, you need to know the visualization of the arm to include the size and bulk, cool temperature in blue color, Sensory evaluation is critical to determine the areas of involvement. Muscle stretch reflexes will be decreased or absent in distribution of brachial plexus injury. The primitive reflexes are also very important since the upper plexus has more frequent involvement. The motor reflex, which by now you know what is motor reflex, which shows shoulder abduction and elbow flexion, is valuable in assessing these active movements. So you can assess the motor reflex and can easily know about the primitive reflex. Torticollis can also be seen in such a situation, and the face will be turned away from the involved arm. Then the range of motion is an important part of the evaluation since the contractures are commonly seen in shoulder adduction and internal rotation, wrist flexion, forearm pronation, and even at the elbow into flexion commonly in later months and years. Electrodiagnosis. So first of all, you need to know what is electrodiagnosis. Electrodiagnosis is basically the phenomena through which we obtain information about diseases by passively recording the electrical activity of different body parts. So it also holds a lot of importance for physical therapists. Um, Diagnostic evaluation should include non-traditional nerve conduction studies because commonly you are going to study the median nerve and ulnar nerves, but in brachial plexus injury case, you are first going to look for axillary nerve, the muscular cutaneous nerve, and the radial nerves. Then you have these sensory nerve action potentials. As these are more sensitive to axonal loss. What are sensory nerve action potentials? The sensory nerve action potentials determine the axonal loss, the loss which is done on the axons. So, if there is presence of snap responses in an insensate area, it is an indication of a preganglionic lesion. So, snaps are the indication of preganglionic lesion due to the location of the sensory cell bodies in dorsal root ganglion. Electromyography may show activation of motor unit potentials in muscles with no clinical motor activity. Then we have electromyographic evaluation, which will be reported of being some benefit, but underestimating the severity of lesions. It has been recommended to be performed early in the first few days and with a repeat evaluation after several months to more accurately identify cases where there is reinnervation occurring and therefore having accurately sorry and therefore having earlier determination of the need for surgical intervention. Plain x-rays may be useful. So you see electromyographic evaluation is of benefit in order to know this, what is this in order to know about the lesions, but sometimes it does not tell you about the severity of the lesions. Other abnormalities may mimic a brachial plexus palsy, including a fracture of the clavicular humerus. Osteomyelitis may also mimic this and has actually been reported as inciting temporary brachial plexus palsy. Neurofibromatosis or other tumors may also cause it. So there are other abnormalities which are going to cause symptoms of brachial plexus injury. So, what can be the treatment? The basic treatment is education. The therapy should start as soon as possible after the diagnosis. Positioning is very important. It should be done immediately. Then we have a range of motion exercises, which will be initiated after the 2 weeks. So, why do we wait for 2 weeks? We wait for 2 weeks because usually it is noted that the pain with the changing position of shoulder that there is commonly pain with changing of the shoulder for bathing or dressing in the first 2 weeks. So it appears that there is some tenderness after the initial brachial plexus injury, which is quickly resolved. It is also important to position the arm so that the baby will have maximal awareness of it. One way to accomplish this is with the use of a wrist rattle on the affected arm so that the baby's attention can be drawn to that arm by sound or vision. Because the weakness of their arm usually limits its forms being moved in front of the face spontaneously. So it is important that the family realize that they need to perform the exercise program several times a day. Education, therapy, positioning, ROM, right after the 2 weeks, and then the splinting, taping, and electrical stimulation. Splinting is also commonly done by the occupational therapy or the physical therapy. Initially, there is frequently wrist drop, so splints may be made to provide optimal position of the wrist and the fingers. Later on, frequently there is an elbow contracture, so splinting is done to minimize that. Initially, you will provide the patient with splinting for the wrist and the fingers in order to avoid wrist drop. Later on, you are going to provide splinting for the purpose of preventing the elbow contractures. Then therapists may also be capable of doing the taping. Electrical stimulation is sometimes done for the brachial plexus palsy, but not very frequently because this is not tolerated at a very young age. So most commonly, it is performed with the surface electrodes to increase bulk by use of sufficient stimulation to get local muscle twitch for approximately 20 minutes twice daily. It has been shown that continuous electrical stimulation to denervated muscles with implantable electrodes will lead to improved muscle outcome after nerve regeneration. Complications: pain, muscle atrophy, joint contractures, joint dislocation, scapular winging, torticollis, body image may be affected, ulcerations from the trauma, and affected arm frequently is shorter and has a decreased circumference. So, what are the complications? Pain, muscle atrophy, joint contractures, joint dislocations, scapular winging, torticollis, body image may be affected, ulcerations from the trauma, and affected arm frequently is shorter, has decreased circumference. Surgical indications. What are the surgical indications? Indications for timing of brachial plexus injury for infants have been controversial. Later brachial plexus injuries are divided into supraclavicular and infraclavicular injuries. So, to decide the what are the surgical indications, first you need to know that brachial plexus injuries are divided into two types, which are the supraclavicular injuries and the infraclavicular injuries. Basically, the supraclavicular injuries are the one which occur the most as 75%, and infraclavicular being the 25% of the injuries. Supraclavicular injuries are generally felt to be due to the traction of plexus. So, if it's supraclavicular injury, it will be because of the traction of the plexus, and these have a worse prognosis than the infraclavicular injuries. There may be a fracture of the clavicle or cervical transverse processes, and supraclavicular fossa swelling may be seen. Dorsoscapular nerve or long thoracic nerve injury may also be present. Supraclavicular lesions may also be due to the falls, large objects falling on a shoulder, such as prelim, skiing, climbing, or contact sports, including the footballs. Other etiologies are backpacks that are too heavy, tumors, and gunshot wounds, lacerations, or animal bites. Those who also have Epsilon syndrome and persistent pain have worse prognosis. So these all such kind of situations are the surgical indications. Infraclavicular brachial plexus injuries are more commonly associated with fractures and dislocations about the shoulder or humerus, occurring more often in older adults. The posterior cord, axillary nerve, or musculocutaneous nerve are classically involved. Infraclavicular plexus injuries may also be due to falls, motor vehicle collision, or tumors. Gunshot wounds, stab wounds, and failed attempts at shoulder reductions may cause infraclavicular injuries as well. So you see why we avoid the reductions or such kind of things with you know unfavorable hands from the unfavorable hands of Jara. Brachial plexus has been reported after axillary crutch use, anesthesia, functioning, particularly with table tilt, and after bony fracture with malunion. For severe injuries later in life, recommendations are for surgical exploration and nerve grafting, most commonly at 3 to 4 months post injury. So, what kind of surgeries we can have in the brachial plexus injury? Microsurgical repair, Neurosurgery, neurolysis, direct nerve transfers into side neurolephy. These are the procedures of the surgeries. Transfer of functionally less important nerve to distal denervated nerve. Oberlin's procedure. Oberlin's procedure includes a partial transfer of ulnar vesicles to a motor branch of the biceps. Transfer of spinal nerve to the supraclavicular nerves is also commonly used for the shoulder abduction. Contralateral C7 transfers to provide adequate elbow flexion as a result, and most patients have had only temporary sensory deficits on the ipsilateral side of C7. Musculotendinous surgical procedures are that latissimus dorsi and teres major tendon transfer to the rotator cuff, along with musculotendinous lengthening, will provide improved shoulder function but no significant change in the bony position of the shoulder or the humerus. With internal rotation contracture and glenohumeral joint deformity, along with a significant abnormality of glenohumeral joint, the rotational osteotomy can result in improved shoulder function along with improved internal rotation contracture. In adults performing a glenohumeral arthrodesis, both in patients with upper plexus palsy with the functional forearm, as well as those in with the total plexus palsy, has shown to increase functional capabilities. The strength of the pectoralis major is a significant prognostic factor for outcome. Performing wrist orthodesis in adults with brachial plexus injury is done for improved function as well as pain relief. So with this, we are done with the part of our lecture with this week. You guys need to learn all the points that come under the topic of growth and development, all the congenital conditions, and then brachial plexus injury as well. Have a safe week till we meet in the next week. Have a good time. Allah Hafiz.